we are lucky to have Mark Solms with us, and I would like to show you his last book. This is published only in English, but it will be also translated into Italian, and to be possible to buy it in a few months. And also the next one, please. You. No, and this is his last book, The Hidden Spring, which has been also translated into Italian by Andrea Clarici. And also, he has done this enormous, huge, really incredible work of translated all the opera Freud from German to English. This is an incredible work, and it is possible, yes, to read it and to see how the translation has been renovated and better understood. So thank you very much, Mark, to be with us today, and please.
Thanks, Claudia. Although we had minimal coordination, as it turns out, what I'm going to be saying builds very nicely on what Rosa Spagnolo just said. She set out the neurobiology of depression, and I'm going to try to integrate that, or parts of that, with the psychoanalysis of depression. In other words, I'm going to give you a paper on the neuropsychoanalysis of depression, as my slide says I'm going to. You might think this looks like a very old-fashioned slide. And the reason for that is that I decided to use the slides that I gave here 10 years ago. I spoke on exactly this same topic 10 years ago at the very first meeting of this wonderful organization. And so I'm going to, although I'm aware some of you many of you were not here, therefore, to those of you who were not here, I'm going to give you more or less the same paper that I gave 10 years ago. But because some of you were here, I'm going to also tell you what's changed, what further developments there have been over these last 10 years. So in a manner of speaking, I'm setting out the stall of the neuropsychoanalytical view of depression, and I'm updating it, or at least giving you some information about developments in this area over the last 10 years. So when I say these are the same slides as I gave 10 years ago, it's the same slides plus some other ones fitted in between. When I gave that paper 10 years ago, this was the slide I began with. From Newsweek magazine, the depressing news about antidepressants. Studies suggest that the popular drugs are no more effective than placebo. In fact, they may be worse. That was the big news at that time. We had been told for 3 decades by that stage that depression was a chemical imbalance, and in particular, the imbalance was a deficiency in serotonin. Depression was a serotonin deficiency disorder, and so therefore you had to replenish serotonin in order to treat, or dare I say, even to cure depression. That was the view until the STAR-D trials in the United States, which weren't trying to test whether antidepressants worked or not. This was already known. It was without question that SSRIs were the gold standard treatment for depression. What the STAR-D trials were trying to do was to discover what sequence should you give them in. If the first order SSRI doesn't work, which one should you give second? And if that doesn't work, which one should you give third? It was exploring an entirely different question. But it was not run by drug companies, it was run by the NIH, and it was a very big surprise to them to discover that, in fact, the premise of these studies was not upheld, that, in fact, these drugs were not that effective. And so that led to further questions as to, well, why did we think they were effective if now we find that they're not so effective? And that led to semi-scandal, which was looking into all the studies that had been done as opposed to all the studies that had been published. And there was a massive bias. Of course, those that were published were the ones that had positive findings. This doesn't only apply to depression research, it applies to everything. If you haven't found anything or if you haven't confirmed your hypothesis, you don't publish. But then again, there was the pernicious influence of the funding of this research by the big pharmaceutical companies. So that was the news. And this was the backdrop in 2016 to approaching anew this question of depression in the wake of the depressing news about antidepressants. What I said 10 years ago was that for those of us who know something about the neural circuitries and the neural chemistries for affective, that is to say, for emotional life, it wasn't a great surprise that serotonin depletion was unlikely to be the cause of depression, and that the administration of serotonin-boosting drugs was unlikely, therefore, to be the specific effective treatment for depression, because there's nothing about serotonin, its action in the brain, that is specific to depression. What it does is a kind of a general all-purpose mood mollifier. It sort of takes the edge of strong feelings. So that's why it helps, it frankly does help with depression. It helps with depression, it also helps with anxiety, it also helps with common unhappiness. And it's frequently, SSRIs are given for common unhappiness. It's a kind of general, as I say, serenity drug, mood mollifier. Unfortunately, it also takes the edge off positive things like libido. And so, it has an effect, but it's a very global effect. There's really no reason to expect that there should be any special relationship between serotonin and depression. This is what we said 10 years ago. What I didn't say, but which I'll say now, but I could have said then, is that treating depression with an SSRI, which is, after all, just a symptomatic treatment, because there's no reason to believe that this chemical has any special relationship with the disorder. It's just treating the symptom. And I could have given you this analogy. Imagine you have chest pain, especially when you exert yourself. And sometimes that chest pain radiates down the left side of your arm. You might go to a cardiologist and report this. And imagine if the cardiologist said, well, I think you need a painkiller. It would be treating the symptom. Maybe they would suggest an opiate to suppress the symptom of pain in your chest, rather than the cause. To treat the cause of the pain in your chest, you would have to understand that the mechanism whereby that symptom, which is called angina, the mechanism whereby that symptom arises is if the heart muscle requires more blood, more oxygen than it's getting, then it causes it pain. And so what's causing the imbalance between the amount of blood demanded and the amount of blood supplied is usually some sort of stenosis of the arteries. And so a causal treatment would be to do something about that. In the interim, you might want a painkiller, you might not, but that's just symptomatic treatment. It's not causal treatment. So the fact that giving SSRIs, might suppress the bad feelings of depression is bad enough in the sense that it's just treating the symptom without any understanding of the mechanism. But it went a step further and said, because this symptomatic treatment helps your mood, therefore your low mood is caused by a deficiency of the chemical that's supplied by that treatment. That's like saying, if you give an opiate painkiller for chest pain in angina, that means angina is caused by a deficiency of opioids in your heart muscle. It's really bizarre kind of thinking. But that took the world by its throat and throttled us for decades. So at that point, there really was, in 2016, a need for us to look properly at what is the brain chemistry, what is the brain circuitry, what are the causal mechanisms of depression. And that's what we spoke about 10 years ago. But now, as I told you, I'm going to pepper my presentation with developments that have occurred in the interim. And one such development is this wonderful paper by Joanna Moncrief. a British psychiatrist in a good journal. You saw it. Georg Nordhoff cited his papers in this journal a few times earlier today, Molecular Psychiatry. And there she published this famous umbrella review. An umbrella review is a review of all the evidence, not just a meta-analysis of outcome studies, but a review of all the evidence relevant to this question. And the question that she looked at was, is depression a chemical imbalance? Is that the cause of it? And most specifically, is the cause of depression a deficiency of serotonin? I've already told you that the drug trials were rather disappointing. Turns out that SSRIs are not such a massively effective treatment. It wasn't such a great surprise, as I said. But what Moncrief showed us in this umbrella analysis is there was really absolutely no reason in the sense of evidence, absolutely no evidence for the view that depression is a serotonin deficiency disorder. She showed, not only did she review the outcome trials that I've already mentioned, but she also showed that in terms of positron emission tomography, where you can tag particular neurotransmitter systems, there was no difference in the neurotransmitter system of serotonin in depressed and not depressed people. There was also no difference in the genes that produce serotonin. There was between the two groups. There was also no difference between the genes that produce the receptors for serotonin and the different subtypes of receptors for serotonin and the different transporters for serotonin and the different precursors for serotonin. There was just, as we say in South Africa, piss-all evidence for believing that this was a serotonin deficiency disorder. So this has taken us a little step further. We said 10 years ago, well, there was no reason to believe that SSRIs would be so effective. There's no reason to think that depression is a serotonin deficiency disorder. The evidence for that view has accumulated and really is beautifully summarized in this paper. By the way, we have the good fortune of having Joanna Moncrief addressing us at our Neuropsychoanalysis Congress in Barcelona in June. Yeah. So you can come and hear it from the horse's mouth. So back to what I showed you 10 years ago, I said there are different views of depression. The psychoanalytic view is that depression means something. The behaviorist view is that depression is a learnt behavior. The cognitive view is that depression is a negatively based belief, or it's based in negative beliefs. The psychopharmacological view, which I've just mentioned, is that depression is a chemical imbalance. And I concluded that slide 10 years ago by saying that the neuropsychoanalytic view is that a chemical imbalance means something. In other words, it's combining the psychopharmacological or neural view of depression with the psychoanalytical view. The psychoanalytical view is that it means something, and the neural view is that there's some sort of chemistry to this, and I'm going to give you lots of evidence as I proceed in my talk today for the view that there is a specific chemistry. We are dealing with neural mechanisms. It's not something, depression isn't something that we can only understand psychologically. That's the whole raison d'etre of neuropsychoanalysis, is that we have to integrate the information that we're gathering from both sides of the great mind-body divide. So I try to summarize that with this statement that a chemical imbalance means something. But of course, already 10 years ago, what we could say was that the chemical imbalance in question is not a serotonin deficiency. Okay, so we move on. What is the something that depression means? What is the something that the chemical imbalance in depression means? And the aim in neuropsychoanalysis is to find one something that explains both sets of data, both sets of observable observations we can make about depression. That is to say, the psychology or psychoanalysis of depression on the one hand, and the neurobiology of depression on the other. How can we integrate them into one story? That's what I tried to do 10 years ago, and that's what I'm going to recap for those of you who know the story. That's what I'm going to try to lay out for those of you who don't know the story. I want to articulate the neuropsychoanalytic view of depression. It fundamentally has not changed in 10 years. There's just new developments, new details. Whoops. I think I must have showed this slide last time. Our patients suffer mainly from feelings, is our claim. And why do I say something as obvious as that? It's because if you go back to the previous slide, depression means something. In the psychoanalytic view, there we mean that the feelings mean something. In behaviorism, you note there's no mention of the feelings. Cognitive view is about beliefs. The psychopharmacological view is about chemistry. And what we were trying to say is that fundamentally, depressed patients, like all of our patients, suffer from feelings. So we want to know what those feelings mean. What does this particular constellation of feelings that we call depressed mood or depression, what is it? What does it actually tell us? Both looking at it psychologically and looking at it neurobiologically. So what I then went on to say is that in neuropsychoanalysis, drawing upon the decades of work on the basic circuitries and chemistries for the fundamental emotions of not only human beings but all mammals that had been collected together under the leadership of Jaak Panksepp at the end of last century, that this was a sort of a summation of what we had learnt through those decades of research, that there seemed to be there's not only emotional needs, of course, there are also bodily needs, many more than 7, but there seem to be 7 emotional needs, 7 needs of the human organism, and in fact of all mammals, that we can specify as or label as emotional needs. And those are the 7 needs on the slide. That hasn't changed. We still believe that there are basically 7, and I say basically because, there's a little bit of a question as to whether something should be labeled as a bodily need or as an emotional need. But basically, these are needs that come with the phenotype. These are needs that come with the species. And these 7 we conventionally label as emotional ones. I might just easily move on because I'll say we haven't changed our mind on that. There's no reason for us to believe that there's not 7 emotional needs. But there has, in the interim, been a growth of opposition to the view that we do have basic emotional needs. And so I need to say a word or two about that. In fact, I also wanted to say in passing, of course, it was 1 year before Jaak died when we had our Congress here in 2016. None of us knew at that point that he was only 1 more year for this world. And I think that Jaak would be, devastated to know how much the criticism of his view has taken root. It was already there in the person of Lisa Feldman Barrett. She had already articulated her alternative view, but nobody was really taking it that seriously in 2016. She published a book in 2017 called How Emotions Are Made, and that had enormous reach. It was a popular book, but it grabbed the popular imagination, and everybody not everybody, but a lot of people started taking very seriously this idea. So let me just quickly summarize what this idea is. It's encapsulated in the title of her book, How Emotions Are Made. She takes the view that we are not born with particular basic emotions that come with the species. And when she says emotions, I must emphasize the same applies to bodily needs. She's saying there aren't any innate affective feelings. There's no such thing as a natural kind called hunger or pain or sleepiness, let alone fear or rage or lust. All of them, she says, are made. They're constructed. On that view, the constructivist view of emotion, all that we are born with is good or bad feeling. It's called valence, goodness or badness, and high or low arousal. So we feel bad in some sort of undifferentiated way, or we feel good in some sort of undifferentiated way, and it's either a high arousal state or it's a low arousal state. On that view, from that, you have to construct cognitively what's going on here. What state am I in? And you formulate a concept. I'm going to call this thing fear. Why? Because my mummy calls it fear. People generally seem to call this sort of thing when you're in danger and you feel bad and you feel high arousal. We call it fear, so I'm going to call this thing fear. And if your mummy didn't call it fear, or your culture didn't have a word for fear, you wouldn't feel fear. It's literally the feeling is constructed. It's constituted as a cognitive construct, as a concept, and that's the word she uses for it, that it's a concept. So the idea that we have these innate emotional needs for Lisa Feldman Barrett is incorrect. These are constructs which are culturally bound, which are historically bound, etc. Now, I need to say, I mean, I could give you a talk on that. Okay, so, but I feel that I would be doing a disservice to our field and to the topic that I'm talking to you about if I didn't seriously acknowledge that in the intervening 10 years, this constructivist view has taken, has become much more influential than I think anybody would ever have imagined. I mean, when I say than I think anyone would ever have imagined, it's just because it's such a bizarre view. I mean, why would you have so many different bodily systems for so many different needs with so many specific circuits and chemistries and particular kinds of receptors and so on, and then you just summarize them all into one thing called I feel good or I feel bad? And then you have to work out, wonder why, and what am I feeling? Is this hunger, or is this sleepiness, or is this pain, or is it just a need to burp? You know, it's really quite extraordinary that such a view, but there you have it. You can't legislate for what becomes popular, and this view has become popular. So I need to just say a few things about it. The one thing is that when she first articulated this view in that book, for example, but also in the years leading up to that, she said there's no evidence that there are specific brain circuits for these 7 specific emotions. The evidence doesn't exist that there is specific circuitry for these emotions. Happily, I'm able to tell you that she's changed her mind about that. Okay, so now in very recent years, only over the last 2 to 3 years, she started to say, okay, there are brain circuits for these specific behaviors, but they're behaviors. The evidence that we have for these circuits is largely based on animal studies, because I'm sorry to tell you, it's very difficult to poke around with an electrode in a human patient's brain, and say, how does this make you feel, and how does that make you feel? In rats, it seems to make them look very frightened. Are you frightened? It's hard to do that sort of thing. So there's much less human deep brain stimulation research than there is animal research, and so Lisa Feldman Barrett and her school now acknowledge that there are circuits which produce these kinds of behaviors. You can reliably produce rage, you can reliably produce fear, behaviors, or survival responses, they're called. But we can't know whether they're actually feeling anything because, hello, they're animals. Okay? They can't report what they're feeling. We have to infer from their behaviors, and we might be wrong. The methodology that's used mostly in human beings is functional imaging studies. And she makes the point that when you use functional imaging studies, you don't see these 7 separate little circuits. And that's because in human beings, of course, you don't just have the single basic raw affect stimulated under experimental conditions. You can't stop somebody from having had a lifetime of learning since they were born with that circuit, and from having thoughts about what they're feeling. So you're getting a much more complicated thing in imaging studies. And Jacques always said, especially fMRI, when functional imaging was first introduced, he was saying, this is not a suitable methodology for us to investigate this sort of thing. We need to rely on deep brain stimulation and on pharmacological probes. So I'll say a little, as I go along, I'll say a little bit more about what human evidence we have that there are in fact such circuits, specifically in relation to those that are relevant for depression. I can say no more about Lisa Feldman Barrett, only because, as I say, it requires a whole lecture of its own. But I'm very pleased to tell you that I have a PhD student who's busy writing a whole wonderful analysis of all of the evidential basis for and against her views. So enough about her. I think it'll have to be. So when it comes to, So this is the neuropsychoanalytical view, is that each one of those 7 emotional needs represents, the black line represents homeostasis, where we need to be. That just as we need to be in a certain temperature range, we need to be in a certain blood oxygen balance, we need to have a certain blood pressure, etc., so too in relation to our emotional needs. So for example, with fear, you have to be not in danger. So for example, with separation distress, you have to be not separated from your attachment figures. So for example, in rage, you need to not have frustrating, impeding obstacles standing between you and what you need and want. So that's the black line. If you're not where you need to be, and please note those things I've just said, although they're emotional needs, they are biological needs. The need to stay safe. So, hello, if you're not safe, you might die. If you're separated from your attachment figures and you're a mammal, and mammals can't look after themselves when they're little, they need to be attached to somebody who cares for them. If you don't have an attachment figure nearby, you die. If you can't fight for your place in the world and everyone gets in your way and frustrates and impedes you and you just say, oh shit, okay, I don't get anything, you'll die. So all of these emotions, they're there for good biological reasons. The red line indicates when you're moving away from where you need to be. And that is the feeling. It's I'm feeling fearful, or I'm feeling angry, or I'm feeling anxious about having lost my caregiver, and so on. And then you have to do something to bring yourself back to where you need to be. And the blue line is showing you, yay, I'm heading back to where I need to be. It feels good. Okay, and each of these apply across those 7 categories. So there are 7 different ways to feel bad, 7 different basic emotions that human beings and all mammals feel, which is when things are going badly for you in terms of meeting your emotional needs, what I'm doing isn't working. It feels bad in these 7 different ways. And there are 7 different pleasures that coincide with this list. The pleasure of seeking, which is curiosity and interest and optimistic expectation, is different from the pleasures of lust, is different from the pleasure of hitting the bastard on the nose and seeing him drop, and so on. So there are these different categories of feeling, and the crucial bit is that green word, prediction. In order to do something that's going to bring you back to where you need to be, you need to have some sort of understanding of, well, what's going on here, what is likely to work. And where do these predictions come from? 2 places. The first is we're born with predictions, which in the case of bodily needs are mainly simple reflexes about how to correct, blood oxygen imbalances, blood pressure imbalances, core body temperature deviations, and so on. There are different reflexes that kick in to get you back to where you need to be. When it comes to emotional needs, we call them instincts, because they're not just simple reflexes, they're complex behavioral stereotypes. These are inborn instincts as to what I must do to return myself to safety. In the case of fear, it is freeze or run away. That's the instinctual behavior. And every mammal, when they're born, when they're in a dangerous situation, they freeze, and if that doesn't help, they run away. Okay? When it comes to rage, if there's something standing getting in your way, something impeding you from getting to the things that you need or want, what do? You hit it, kick it, bite it, do anything you can to get rid of it. Okay? And that's called affective attack. That's the inborn prediction, instinct. When it comes to separation distress, it's separation distress vocalizations and searching. Mama, you lost me, and you look for her. Okay, that's an inbuilt response to separation distress. Now, the problem is we're glad to have these inbuilt predictions called instincts, but they're not enough because it doesn't always work. It's not always the right response, and these different needs conflict with each other. And I'm going to say something more about that in a moment, which means that if you have I'll say something about it now. If you have an inbuilt response, anybody that frustrates me, I hit, kick, and bite them, and you have another emotional need, my caregiver, I need to keep her close to me forever and always, and to have her love and affection and attention, Well, what if your mother frustrates you? What if your mother gets between you and what you want? And whose mother never frustrated them? So you can't attack her, you need her. So you can't, these inbuilt predictions conflict with each other. They are what Klein would call part-object relationships. You have to integrate these two aspects of your mother into one whole object who both you love and who irritates you. And then you've got to find, well, how do I deal with this ambivalence, with this ambiguity, with this complexity, and how do I deal with it in this situation as opposed to that situation? My little brother, I can kick him. My mother, I can't. My father, neither, for different reasons. And so it goes on. So this green thing about predictions is we have to learn from experience what to do to get ourselves back into where we need to be, in other words, how to meet our emotional needs, and we have to learn this in a flexible, nuanced, context-sensitive way. And so the great task of emotional development is learning how to meet your emotional needs by developing a predictive model. Now, Dia Vittorio called it metaphors. Please note, I'm talking about it in a very concrete way. Okay? It's like basically what Freud called a wish. You have an experience of satisfaction, and then you want to repeat that behavior to have that same experience of satisfaction again. You have a noxious experience, you want to avoid that behavior. These are what I mean by predictions. It's the same thing as what the behaviorists called operant conditioning, the law of effect. You repeat those things which work, you don't repeat those things that don't work. So memories, as Paul Moore quoted me saying, they're about the past, but they're for the future. You learn from past experience what works and what doesn't work, so that you have predictions as to what to do in the situations that you find yourself in. So this is the basic model that we have. And when it comes to depression, it's failures to learn how to meet these two emotional needs seem to be the crucial ones. In fact, the crucial one is panic grief. Panic grief has to do with attachment. It's called the panic grief drive. It might as well have been called the attachment drive. It's the drive to attach, which, as I said earlier, all mammals have to do. We mammals, when we're little, cannot fend for ourselves. So we have to have somebody looking after us. So we look around and see who's reliably caring for me, and then we attach to them. And then if we become separated from them, we suffer panic or grief, and I'll say more about that later. The hypothesis, the neuropsychoanalytical hypothesis, is that depression arises from a failure to satisfy this need. It's a very simple hypothesis. In other words, the inborn, innate, instinctual behaviors, which I'll explain to you in a moment, the ones that we have in relation to this need, that we have failed to learn better ways to meet these needs and integrate them with other needs, and so we fall prey to depression. I mentioned rage, which I didn't highlight 10 years ago, because panic grief frequently conflicts with rage for exactly the reason that I just told you. As Bion put it, a good object absent is a bad object present. Okay, the mummy, where are you, is the missing good object. And mummy, where are you, is the frustrating, where the hell is mummy? Okay, so it activates these two feelings very commonly. And our great insight by the first neuropsychoanalyst, Sigmund Freud, was that depression arises out of this sort of ambivalent cathexis of a love object. When we lose that love object, what Freud says, there's a failure to mourn in the normal way because of the ambivalent nature of the attachment in the first place. So all the way back to 1917, it started there, this idea that depression has to do with these two feelings toward attachment figures. Freud called them love objects. But then through Bowlby's work, we came to talk of attachment figures, and I'm going to say much more about Bowlby's work in a moment. But the point I'm making for now is that when I said that in psychoanalysis we say that feelings mean something, that depression means something, Freud was the first one to articulate such a view. He was saying that the meaning of depression is it's a response to the loss of a loved object, which we now call an attachment object. It's a response to separation distress, to the loss, to the separation of and loss of an object whose love and care and affection and attention we need. And then, as it happens, this also arouses hostile feelings toward the lost object, and those hostile feelings, according to Freud, get turned inwards. And this is the basis of the self-hatred and the guilt and the punitive negative thoughts that we see in depression. So remember what I'm trying to do. I'm trying to articulate the neuropsychoanalytic view, and this is the psychoanalytic side of the neuropsychoanalytic view, is that this idea that these two drives, the drive to attach, to keep a love object, a caregiving object close to you and available to you, and your ambivalence toward that object, the idea that these two drives are the germane ones in neuropsychoanalysis, from the psychoanalytic side, can be traced all the way back to Freud. Now, what is the evidence for Freud's view? I find it quite a remarkable thing how this has been overlooked. And this I told you 10 years ago. Those of you who were here might remember. In order to be diagnosed as depressed, according to DSM-4, you have to have those top 9 things. You have to have 5 of them or more, and especially you have to have the first 2. And the first 2, as Rosa was telling you, is depressed mood most of the day, etc., and markedly diminished interest in all or almost all activities. So these 2 things, depressed mood, another low mood, and anhedonia, anergia, lack of energy and lack of exploration, lack of optimistic, hopeful interaction with the world. And then those other things, 3 of them you need to have, then you're depressed, according to DSM-4. And then you go boom, boom, boom down to criterion E, and that's where the remarkable thing occurs. The symptoms, in other words, those things which qualify you as depressed, don't count if those very same symptoms can be accounted for by bereavement, in other words, after the loss of a loved one. I mean, it's astonishing. It's saying that this constellation of affective states, especially the 2 main ones, the anhedonia and the anergia, the low mood and the lack of optimistic, energetic behavior, that these very same things occur in a normal, meaningful psychological situation, which is when you're bereaved. There you go back to Freud's title of his book. By the way, I gave it in the German. That's translated in English as mourning and melancholia. It could just as well be translated as grief and depression. I mean, literally, it could be translated grief and depression. And Freud's saying depression is a pathological form of grief. And here, the DSM-4 is saying the same thing. I wish more of you were nodding. I mean, don't you agree? It's astonishing. So I know what Rosa said is true, that ordinary bereavement isn't depression. This is kind of like, bereavement on steroids. It's like too much bereavement, or bereavement that you can't stop, or bereavement when you don't know what they're bereaved about because it's not obvious what they've lost. Okay, but it's the same emotional phenotype. It's the same constellation of feelings and behaviors. It occurs in this pathological condition called depression, and it also occurs in normal life under very specific conditions, namely bereavement, i.e. after the loss of a loved one. Astonishing. DSM-5 says much the same thing, except they basically say you can't tell the difference between the 2. It's not saying that if it's due to bereavement, then it's not depression. It's saying, well, these 2 things are kind of like, they look like the same thing, and the clinician has to decide which one am I dealing with. Okay. So again, I mean, it's really amazing. So we're looking for what does this symptom mean? Symptoms, by the way, always mean something. Symptoms are symptomatic of something, and we're talking here about emotional symptoms, and we're saying what does this particular constellation of affects, of emotions, of feelings mean? And here's our big clue. It means something to do with loss of a loved one. And so it really it hasn't built very much beyond what Freud taught us from the psychological side. But it is an astonishing fact that even in the DSM-5, they're still saying this, that this constellation means something in normal life. So now, I told you that building on Freud came Bowlby. What Bowlby did was just observe through his friend Harry Harlow and others that this thing, a grief response, that it is a phenotypic response. It's something that's built into our species, and it doesn't only happen with all human beings, it happens with all primates, and in fact it happens with all mammals. And here Bowlby describes the panic side of panic grief. You notice that name of that drive has got two parts, panic, grief. And those two words coincide with what Bowlby called protest and despair. It's just different words for the same thing. It's just words. It's been observed since, in fact, the 50s with Harry Harlow's work, and into the 60s with primates and with humans, and since then with all mammals, that this is how mammals respond when they're separated from their attachment figure. So Bowlby describes in the human, funnily enough, he thinks humans are only males, but there again, that's another matter. It may begin immediately or may be delayed. It lasts for a few hours to a week or more. During it, the young child appears acutely distressed at having lost his mother and seeks to recapture her by the full exercise of his limited resources. He'll often cry loudly, shake his cot, throw himself about, and look eagerly toward any sight or sound which might prove to be his missing mother. All his behavior suggests strong expectation that she will return. Meanwhile, he's apt to reject all alternative figures who offer to do things for him, though some children will cling desperately to a nurse. Then it shifts from panic or protest to grief or despair. Despair succeeds protest. The child's preoccupation with his missing mother is still evident, though his behavior suggests increasing hopelessness. The active physical movements diminish or come to an end, and he may cry monotonously or intermittently. He's withdrawn and inactive, makes no demands on people in the environment, and appears to be in a state of deep mourning. Okay, so you see this is what's described as the depressed phenotype, but it's the normal version of it. This giving up hope, loss of energy, lack of optimism, lack of high mood, of euthymia. Now, something that's happened since then is that Volker Kernen has given us this wonderful paper where he maps out the circuits for these two behaviors. The gold one on this slide is the anterior thalamic radiation, which is heavily modulated by mu opioids, and the medial forebrain bundle in green, which is heavily modulated by dopamine, and particularly by what is broadly called D2 type dopamine, acting on D2 type receptors. So there we have a picture of these two circuits, which, remember, Lisa Feldman-Barrett admits do exist, okay? But she says they activate survival behaviors. We don't know what feelings are associated with them. So here's the first one, the one that's mu opioid mediated. This is the slide that I showed you 10 years ago. I've described for you from Bowlby what happens. The child does this separation, distress, vocalization, crying out and searching for mother. That child was in a cot, but if it wasn't in a cot, it wouldn't just be shaking on the cot and looking at the door. It would be searching and looking for her. And that's the mu opioid mediated behavior. And it's important that it's mu opioid mediated because mu opioids are highly addictive. The attachment to the mother is an addiction. And the fact that one way of treating this symptom is to self-medicate with opiates is leading us into our next section of our conference, which is on addiction. And it's no accident that these two things are in the same conference. I've already told you what this is all about. This is a slide I showed you 10 years ago. The top one was a cartoon made of a imaging study, a PET imaging study that Damasio, it was Panksepp and Zubieta had just done in 2003, and showing how the circuits seemed to be exactly the same as what they had mapped out in guinea pigs and other mammals. It's the same circuit. Rosa mentioned that in the functional imaging studies of depressed patients, there's a hyperactive area in the subgenual cingulate gyrus, anterior cingulate, area 25, Brodmann's area 25. On the basis of that observation, a neurologist named Helen Mayberg put electrodes into the white matter, into the anterior thalamic radiation, just underneath the subgenual cingulate cortex, and she did this in chronically depressed patients. And in this way, she zapped them out of their depressed mood. And this is partly, I mention it to you because it shows that this circuit in human beings, it's not just the behavior, they actually say, you know, I actually was in theater with Helen Mayberg where a patient said this, which I'm going to quote to you because it's so typical, so indicative of the kind of change in mood that this deep brain stimulation brings about. The patient who's been a burnt-out, chronic depressed patient wouldn't get permission to do this if the patient hadn't tried everything and got nowhere. And the patient said, I've suddenly realized you guys are all caring for me. Thank you. Suddenly felt looked after. That's one reason why I mention it. There's the feeling that goes with the behavior. She can report it. But the other is, remember, this is neuropsychoanalysis. We've got to get our heads around the fact, how does this happen? Okay, we've got this whole story about Freud, you know, and mourning and melancholia and psychodynamics and lost love objects and blah, blah, blah. But there's also this surgical intervention. Okay, how do we reconcile our psychoanalytical ideas with this? Well, I've told you how. It's one of our basic emotional needs. It's a drive. It's the drive to attach. Freud didn't know about that. Now we do. We know where it is anatomically. We know what it does chemically. Helen Mayberg, by the way, said all this does is open a window. I'm not recommending this as a treatment for depression. It's symptomatic. She said it opens a window, then you've got to do psychotherapy. That was her view and remains her view. Our colleague Yoram Yovel, who was at that first meeting in 2016, on the basis of exactly this theory, tried giving low-dose opioid drugs to patients who were not just depressed, but suicidal. In other words, they were in the protest type of depression. And he got very good results. The fact that he was able to get ethical approval for doing this study in an era where everybody still thought SSRIs, you know, were the gold standard treatment was really quite an achievement. And the only reason he could is because his patients were suicidal. In other words, you can't give a drug that takes 5 weeks to work. So proof of concept is why I'm showing you this. Now we move to the, because I have to watch the time, because I've got 10 minutes, haven't I?
No, you have, yes, 10 minutes.
Yeah, so I have to hurry. And it's my great failing, I talk too much. I'm sorry. I'm having fun, I talk too much. So here's the second circuit. The mu opioid-mediated panic feeling activates kappa opioid, dynorphin, kappa opioid mechanisms, which shuts down the seeking drive. And so that's where you go into the despair phase, what Panksepp calls grief. And everything that we know about this circuit, you know, it is a whoopee, optimistic, enthusiastic, interested, interactive, engaged with the curious about exploring the world. The opposite of all of that is what happens when the system is shut down, and then you have depression, and then you have despair, and then you have abulia, and then you have anhedonia, and all of that. When Rosa showed her slides about the monoamine, she said, the big missing one here is dopamine. You bet, okay? Because the opposite of what seeking does, the seeking is mania. Switch off seeking, it's depression. Okay, and so that's what, according to the neuropsychoanalytic hypothesis, this is depression is the shutting down after the protest phase, going into the despair phase. Now remember, if your protest behavior works, remember what I said about learning from experience, better predictions about how to, if you can actually get your attachment figure back, you don't go into this. This is you giving up when it hasn't worked. Giving up is the other inbuilt prediction. All mammals do this. They give up. There's all kinds of reasons why they do that, but I hope you can see why it's a little bit of a stereotype prediction. All I ever do when mummy doesn't come back, I just give up and lie there in a heap. Okay, it's giving up hope is the built-in prediction of what you should do under those circumstances. There's complicated biological reasons. As I say, I'm not going to go into all of that for now because I don't have time. But you need to get better predictions than that. Okay, so if you've learned better ways of dealing with loss, better ways of dealing with separation in the case of protest, and better ways of dealing with loss in the case of despair, then you're not stuck in this pathological. It's pathological to have no other way of dealing with this. That's the abnormal form of mourning that we were talking about earlier. Lots more to be said, but I said all of this last time. Here's, again, proof of concept. This is what happens if you stick an electrode into the dopaminergic midbrain. This was done by Blomstedt. 5 seconds after switching on the electrode in a human being who can speak, what does she say? She starts crying, and she verbally communicates feelings of sadness. This is shutting down dopamine. Guilt, uselessness, and hopelessness. She says, I no longer wish to live, to see anything, hear anything, feel anything. When Blomstedt says, why are you crying? Are you in pain? She says, no, I'm fed up with life. I've had enough. I don't want to live anymore. See, depression. This patient has no psychiatric history. When asked why she was sad, she says, I'm crying over myself, of course. I'm hopeless. Why am I bothering you? The depression, you can't call it anything else, caused by an electrode being switched on in the midbrain, shutting down dopamine. Switch off the electrode. 90 seconds later, she's a little bit manic, and then she's fine. And the patient very kindly let the surgeon do it again, and it brought on the depression again. Okay, it's really, just proof of concept, but again, I'm saying this in relation to Feldman-Barrett. You see what I mean? These circuits, it's not just behaviors. The patients describe the feelings. I told you that Kernan had mapped out that circuitry. The reason that Volker Kernan, who's a neurosurgeon, at that time he was in Bonn, I think he's now in Freiburg, is he, Georg? You don't know him. He mapped out that circuit because he wanted to stick an electrode into it, as surgeons do, and he did. And this is him reporting, again, antidepressant effects of sticking electrodes into the medial forebrain bundle, in other words, into the seeking system, and tickling it. And I was with him at that time in Bonn, and I've seen it. Patient on a burnt-out, chronic, depressed, treatment-refractory depression, patient saying, suddenly, I have an idea, I'm going to go traveling this summer, You see the seeking just switching on. But again, of course this is symptomatic. Of course this is not treatment for depression. It's just proof of concept that this is the system that does the thing that we're saying it does. Now, I just want to mention, because I'm very near the end, because I have to be very near the end, don't forget rage. Okay, so that's the panic and the grief side of it, of the separation distress hypothesis of depression. I hope I've explained the concept in a way that's understandable. I've showed you that this particular brain circuitry means something. Okay, although it's brain circuitry and brain chemistry, I didn't mention, again, with addictions, cocaine activates the seeking system big time. So do amphetamines. Okay, and this, one of the reasons why people are addicted to these things is because they're antidepressants. So again, as Rosa was saying, the big missing item, for my purely scientific reasons, have tried these substances out. And I can tell you that they are very antidepressant. Okay, look, I'm still happy. It really is, and Freud, by the way, amazingly, Freud recommended, briefly in one sentence, cocaine might be an antidepressant, but we won't talk about that. So that's that side of it. I'm just saying, don't forget the ambivalence. Freud's great discovery in 1917 was, this is a pathological form of grief. That's what depression is. It's a response to loss, but then he says, of an ambivalently affected object. The rage aspect of it, it's so obvious to any psychoanalyst who's treated depressed patients, the rage aspect of it, but it seems it's only us who see it. So I'll just show you the circuit for that. I had a student, I said to her, in guilt, which is the inhibited form of rage. Remember, I said it gets turned inwards because of the conflict in relation to the attachment object. I said, let's image what it looks like when you're in guilt. And hey presto, what we found was indeed that the rage circuitry is activated together with, it's the wrong slide. Together with orbital frontal circuitry. So this is the wonderful thing, that we can actually have testable predictions arising from these things, and this is the wonderful thing of linking psychoanalysis to neuroscience. Now, for closing, because it makes all these other methods available to us. Now, for closing, I need to just mention one of the things that is very well established, that was very well established in 2016 already, in fact, long before 2016, is that adverse childhood experiences predispose you to depression. So I don't know how the thought was as to what adverse childhood experiences were meant to do to your serotonin circuitry, but nevertheless, it was well established that adverse childhood experiences are a major risk factor for depression. And there's two things that I want to say about that. In fact, I think I've got these slides in the wrong order. I just wanted to say that these two students of mine have just finished this study, which is not yet published. They're about to submit it for publication, where they looked at the adverse childhood experiences of depressed patients to see, is there a particular propensity to do these adverse experiences, if they are separation distress experiences, are they more predictive of depression than general adversity? And yes, that's what they found. But this has not yet been peer-reviewed, so maybe it's wrong. But I don't think so. And that leads me to this, and this, I think, is my last... No, it's my third last slide. Marianne Leutzinger-Berleber, since I spoke to you in 2016, she did a really good, big, randomized controlled trial comparing CBT for depression with psychoanalysis for depression. And what they showed at 3 years post starting the study, and they published it in the Canadian Journal of Psychiatry, it's not the one I got on the screen now, it was 2018, was that the results are equally good. Not better, not worse, equally good. That CBT for depression, major depression, and psychoanalysis for depression, major depression, you get the same outcomes, as measured by the Beck Depression Inventory, okay, as measured by standard behavioral symptomatic checklists. So I wasn't able to tell you that in 2016, now I can tell you that. It's nice to know. It's nice that psychoanalysts are submitting their work for empirical scrutiny to see if it works or not, and what they showed is that it's equally good to evidence-based cognitive behavioral therapy. The evidence is equally good that psychoanalysis helps, equally good, no better. Then what they showed, Marianne Leutzinger-Berleber's group, is that that's in terms of symptom relief. But if you compare what they call structural change, which is a psychodynamic measure rather than a cognitive behavioral measure, the structural change, basically personality change, the defensive organization of the personality, the quality of the object relations and so on. There is a significant difference between the psychoanalytic and the CBT patients at 3 years in terms of that. That's the other thing I wanted to tell you. And the last thing I wanted to tell you is this paper that she published last year. No, 2024, in the British Journal of Psychiatry, which showed that at 5 years, if you compare CBT-treated with psychoanalysis-treated depressed patients, they on average do the same. At 3 years, the psychoanalysis patients do better at 5 years, and this, by the way, is a consistent finding. At follow-up, the psychoanalytic patients do better, psychoanalytically treated patients. But the really interesting thing in this paper, in the BJP, is that it correlates with and is mediated by childhood adversity. In other words, those depressed patients who have the higher childhood adversity, they respond better to psychoanalysis than to CBT. So that's very interesting in relation to what I said earlier about the whole business of learning how to meet your emotional needs. If you're born into an emotional environment where there's not great attachment figures available, it's hell of a hard to learn how to meet your attachment needs. And so I will end with the 2 slides that I ended with last time. Is Freud dead? Asks Time magazine. No, says Newsweek magazine. Thank you very much.